final speaker for today, Dr. Gerard Clancy, the president of the University of Tulsa.
My thanks as well to the Warren Foundation and to LIBOR and to the LIBOR team for putting this on and having the courage to talk about this. So my story, I'm going to talk about how we're educating our physician workforce on this, and it's been a very interesting past 6 months or so on that. It was in September or so, I was teaching over at the OUTU School of Community Medicine, and I teach a class on health disparities in community medicine. And the students came to me and said, and these are second-year students, can you give us a lecture on marijuana? We don't understand it at all, and we know what we're heading into. And we're not getting it in any of our physiology classes or pharmacology classes or anything like that. And so I started putting together a 2-hour short course for the medical students, and I gave it to them, and it went really well. And they told the first years and the third years and the fourth year medical students, so they asked, so I did it again for them. And then they told the OSU Medical School, and I did it for them. And next week I'm off to Notre Dame to do it as well. And with a high of 5 degrees in South Bend, which is going to be great. And when I start my short course, I start out by saying that anytime you start talking about marijuana, you are going to have an emotional conversation. It's emotional for everybody. It's emotional for the patient. It's emotional for the physicians. It's emotional for the business that is happening. It's emotional for law enforcement. It's emotional for the legislators. You cannot really hardly ever have a conversation that is pretty boring about marijuana. And I let the students know, first and foremost, you need to realize that 85% of Americans want availability of medical marijuana. And so that's your starting point. Our patients that we take care of have been voting with their feet. This is a dispensary in Pueblo, Colorado, which would be right here. And they asked the question, when you're at the marijuana dispensary, tell us where you're from. Well, this is Oklahoma, right here. And you see a huge amount of people before 780 was passed traveling to Pueblo, Colorado for marijuana. So it is highly emotional. And it's emotional among patients in part because they're frustrated. They're frustrated with the medical system not being able to care for certain conditions or caring for conditions that lead them into pathways that they didn't want to go to, such as opioid addiction and stuff. So it's highly, highly emotional that way. And it's emotional for the cities. How we have orchestrated taxation of marijuana business has now led to a dependence of cities and states on that revenue now. If you look at Colorado now, it's $1 billion a year industry. And some of the little towns in Colorado were saved by marijuana as well. Oakland wants to be the Silicon Valley of pot. So it just shows that it is small town business and it's big town business as well. There are now stocks that you can buy on the Canadian market that are focused on marijuana. And Coca-Cola and Marlboro and Constellation Brands, which is a group of beer companies, very, very interested in CBD and THC as well. So it is emotional at that business level as well. So I'm going to talk a little bit about the state of medical education in America on marijuana, and then I'm going to give you just a few snippets of the course that I developed for the students and just comment on what some of their reactions have been to some of those points. So in this study, 258 residents and fellows were surveyed about marijuana. And 89% felt that they were not prepared to prescribe medical marijuana. And 85% had not had any education on medical marijuana as well. So that was with one survey. And it was repeated again when they asked the medical school deans, how are you doing as far as medical marijuana? And so this is 101 medical schools. That's about 2/3 of the medical schools in America right now responded. 67% of the deans said their graduates are not prepared to prescribe medical marijuana. And that 25% of their trainees really don't know anything about marijuana as well. So those are pretty damning numbers as far as what the physicians are heading into. across Canada, where legalization has been more established, 426 physicians were asked about their knowledge of medical marijuana. And they really had significant knowledge gaps in dosing. Dosing was number one. They have no idea as far as what dosing is. They don't know about the different forms of the cannabis. They do not understand the regulations, and they do not understand the safety risks and warning signs. So we're really starting from scratch as far as where physicians are. Now, we talked earlier about research, and Cy made a really important point, and Martin made a very important point at the beginning as well, that pyramid. That pyramid is really a pyramid of trust for physicians as far as what they do for their patients as far as trying to help them. And the higher up on that pyramid, the more the physician has trust that this treatment is proven and going to do well for someone. Well, marijuana has been around for 6,000 years, but in the age of modern medicine, it has not been researched. And so that level of trust among physicians is just not there because we haven't done the research going forward. 311 pharmacy students were asked about marijuana, and what they found out is that they were low in accurate responses for diseases and conditions that might benefit from marijuana. They only endorsed cancer and glaucoma as the conditions that marijuana would be considered. 13% noted that they received some instruction on medical marijuana while they were in pharmacy school, and 90% felt they needed more instruction as well. So the state of education for our emerging clinicians needs additional help. So this is the short course that I've developed. It takes about 2 hours to go through, lots of engagement back and forth with the students. It's divided into 5 parts. We start with the biochemistry of cannabis and neurotransmitter systems. This is really important as far as building trust with physicians as well. Physicians are geared to understand the biology first before they will ever do anything as far as treatment. They want to know the physiology, the biochemistry, in the molecular biology at a deep level. They do not want to be working in mystery territory. So they ask a lot of questions about that. Then I go into recommendations and not indications. We go into risks, we go into legal implications, and then we go into the detail as far as making a marijuana recommendation. The objectives of the course are to really understand the emerging neuroscience. The endocannabinoid system was discovered really in 1992. I had never heard of it when I was in medical school. Anandamine, which is the primary neurotransmitter that THC mimics, I had never heard of until I started doing some of this just investigation into this short course. We talk about where and when have marijuana compounds been helpful to patients. We talk about the growing concerns, and you heard a lot about that today, on the impact of heavy marijuana use on that developing brain in uncovering psychosis and in essentially kickstarting a vulnerability for schizophrenia, which is a very, very serious condition. We go into the understanding the legal issues regarding making a recommendation and the role of a physician in making a recommendation. I'm just going to show you some sample slides that we go through. We start with the chemistry part of it, and I want them to realize that marijuana is a highly complex compound. 426 chemicals so far discovered in it. 60 of them are psychoactive. 2 of them do we have much understanding as far as how they work. So it's very much a mysterious, new, emerging science as far as understanding the endocannabinoid system that is where marijuana, where THC and CBD do their work. The students are also fascinated in the legal aspects part of this, and I'm going to show you just one of the areas that they get highly emotional, all physicians get highly emotional on, is the fact that it is Class 1 controlled substance, alongside bad boys like heroin and ecstasy and LSD. So that gets everybody's pulse up right away. We go into the difference between prescribing and recommending, because this is important as far as the federal interpretation of what a physician can and can't do. A prescription is an order to a patient and to consume a controlled substance, and an order to a pharmacist to prepare and distribute the substance. That's a prescription. Issuing such an order for a Class 1 controlled substance is aiding or abetting a crime or a conspiracy to violate a federal offense. That's why physicians get nervous about this, obviously. The Ninth Circuit Court of Appeals in 2002 and 2003 made the following interpretations, though, and the U.S. Supreme Court has refused to hear an appeal. They said recommending the use of cannabis for medical purposes is permitted. Indeed, it is protected. An integral component of the practice of medicine is the communication between a doctor and a patient. Physicians must be able to speak frankly and openly to patients, and such speech strikes at the fundamental interest behind the First Amendment. So you can't prescribe because it's a controlled substance, but you can recommend because it's free speech. That's the logic. So in making a recommendation, I break it down into nuts and bolts for our students. A physician may discuss treatment options, including cannabis, discuss the pros and cons of treatment with medical cannabis, recommend that a patient consider use of medical cannabis to offset symptoms, and sign a form to that effect. That's recommending. But a physician may not order a patient to consume medical cannabis, may not provide instructions about the amount to consume, because that would be prescribing. Provide instruction on the form in which medical cannabis must be taken, because that would be prescribing. And order that medical cannabis be prepared or distributed to the patient, because that is prescribing. I was in California this summer as I was running down the beach at Venice Beach. And I was really kind of after this, I'm smiling. I thought, I got to take a picture of this. This is interesting. Green Doctors, $40. As soon as I took this picture, somebody came out in green scrubs just begging me to go in. Come on in, come on in, come on in. It'll only take 10 minutes. We can get you some marijuana. I'm not a California resident. No, we'll work it out. My shirt says Tulsa on it right here. I mean, I've got a twang even. I mean, but it was really, it's as we think about the future of Oklahoma, we can't fall to this level. We can't. It is, and it is so important. Yeah, it really, really is. This was on the door. Do you suffer from migraines, insomnia, eating disorders, anxiety, depression, chronic pain, glaucoma, nausea, arthritis, AIDS, ADD, ADHD, cancer, or many other disorders? We just can't do this. We can't go there with this. And that's really, Dr. What's his name? Dr. Grantham, Dr. Grantham, I know him. Dr. Grantham mentioned about all those rules and regulations and oversight and bylaws alongside a physician. This is going to be important as we head into this, that we are still following the best standard of practice out there. The Tampa Bay Times put out this report earlier this year, and it's something that we need to watch for in Oklahoma. What it looked at is the physicians in their medical marijuana program, and there was a group of physicians, a higher percentage than across the board in Florida, that were more likely to have been disciplined and more likely to have charges of crime as well. So we can't have the medical marijuana clinics fall into this level of care or at all. We've just got to make sure we keep those standards up there. All right, I think that's it. I think I'm done. I'm done. We're done. All right, thanks.
All right, thank you, Dr. Clancy. So in spirit of the town hall meeting, well, I guess the question, there were two questions for you that were submitted by one person. The first one I think you answered. What is the status today of teaching medical students about cannabis at the OUTU School of Medicine? But the second, what are the plans for the future?
So I think it's, that's why I showed those first few slides, that it is here. And physicians, you're in the middle of it by way of legislation and public vote. This is not the traditional way that a treatment is developed in America as far as drug trials and then introduction and then lots of CME. Instead, it's just here. Here it is. So there's a huge amount of catching up that has to be done. And it's interesting that there's not a whole lot of expertise out there as well, because again, we haven't had, during modern medicine, the research time to be able to develop it. So the foundation of knowledge that physicians are going to accept as of the quality that they want is pretty low. So
do you see the quality of medical education on marijuana improving in the state of Oklahoma in the years ahead?
Oh, yeah, yeah, absolutely.
Good. Questions from the audience? This woman right here. Yeah. Oh, wait for the microphone.
It's Ryan.
Hi, Dr. Clancy.
Ryan.
Great presentation. What do we do in the short term? Because obviously there's demand. We have all the major systems not prescribing this. How do we prevent those types of doctors being the types of doctors that write these prescriptions?
Yeah, I think, you know, at first there was a lot of groaning about the board certification requirement, but the board certification requirement is really important. To be able to maintain your board certification status, it's regularly tested, you're regularly evaluated, so at least there's somewhat of a safety net there. But Rania, I mean, I'm learning as we're learning.
Question at the front.
Obviously, we're just at the beginning of teaching doctors. What about teaching nurses that support the physicians? I'm in a family practice. We have chronic pain patients. I need this knowledge as much as the physician writing the prescription because I'm his support in the clinic. What's being done to support the other healthcare ancillary providers?
I'll ask Dr. Schumann, who has a bigger health science college than I do. Anything, John, that you know of? I think you know of, yeah.
Other questions? In the back, way in the back.
Dr. Clancy, is there a way for us to access your lecture?
Yes, yeah, absolutely.
Because it's not on YouTube. I just ran a search.
You know, in part, I have a lot of people have asked for it, and in part because it is so emotional, and I want the delivery to be in the right context. That I've not published yet. Maybe that's the next thing I need to do is try to figure a way that we can publish it. Yeah.
Do you collect surveys of the students before and after the class?
We do. Okay. It goes from, you know, all I get is 5 stars.
Of course. Question over here.
I have a question about what we know about drug-drug interaction with the other medications that are being given for our common comorbidities.
Yeah. Again, we're still at that starting point as far as any research, because research in the past of this in general has been just so restricted because it's class 1, and so no one's touched it. We do know that in the era where a lot of supplements were used alongside traditional psychiatric medications, lots and lots of trouble with that. Lots of trouble. That someone, just because it said all natural and it was a supplement, it was a store, somebody thought, oh, this is fine. Well, that is very powerful psychoactive supplement that you're trying to treat your depression with alongside your Prozac, and people were having terrible, terrible reactions. Terrible reactions.
I mean, one question that I have related to cannabis is in terms of what are potential populations where there might possibly be an interesting effect. So I work with eating disorders patients, and these are patients who self-induce weight loss and really have a fundamental shift in how they respond to appetite in their hypothalamus, which has cannabinoid receptors. And so prior to this meeting, I was looking to see, is there any evidence that cannabis might actually help improve weight gain, prevent weight loss, and prevent some of the mortality. But of course, there aren't really any good studies out there to look at this kind of question. So I think we really do need more ability, more funding, and more sort of loosening of regulation on the research side to look at this. Other questions? If you want to take it, go. Yep.
I've loved this feisty debate for years with some of my friends about the pros and the cons, and just kind of having this conversation about medical versus recreational. I think that, You know, a lot of people who supported medical, you know, I think some people are really rethinking, you know, because of all of this that comes with medical, you know. I just wonder your opinion on, do you think that we should have maybe just gone for recreational? Because there's a part of me that thinks it wouldn't put doctors in these positions in the first place.
Yeah, you know, I'm still just at such a foundational level. I'm not sure I can answer that question at all. I just don't know. Yeah.
Other questions? Yes, sir.
Yeah, I'm a mental health professional, and it's a mix of art and science, and that's what I'm interested in, is where those two intersect. And it seems I really appreciate what you had to say, because it's such an emotional issue, and I'm interested in where the science and the art intersect over this issue, because I get frustrated with the two. Almost it feels like polarization, extremes. I wonder where we can come together. It seems like we're going to have to come together to do that research and find out weed out what's false and what is true, and there has to be some listening. So that I also want to say thank you for doing this, because I think this is part of that. So.
You know, one of the things that drew me to psychiatry, this wonderful mix of every person that was asking for help in front of you, there was a biology and a psychology and a sociology and an environmental, and everyone, that just how that all mixes together into the problem that the individual is coming to you for. All of those things have to be addressed with every individual. And that's the beauty of psychiatry, and it's the complexity of psychiatry as well.
Question down here.
Yes, if you're say a psychiatrist, and you know your patient has a medical marijuana card, they're taking marijuana, and how can you really treat them with other drugs for their other psychiatric conditions?
Yeah. So that, you know, I talked about the difference between prescribing and recommending. Well, there's no law that says I can't be very aggressive about not recommending. And for an individual with a mental illness, yeah, I mean, just from the evidence I've seen so far, it is very rare that any of the mental illnesses are going to be well treated by anything with THC in it. You just don't see it. And so I would work really, really hard and say you're working against your mental illness here.
Okay, so I think that's going to wrap up our conference. Thank you very much for attending. Please give a warm round of applause for our speakers, Dr. Clancy, the William K. Warren Foundation, and the Laureate Institute for Brain Research. And thank you to TU for hosting.